Okay, so we're going to go through monitoring and managing long-term conditions, and we're going to mainly be focusing on diabetes. So we'll look at type 1 and type 2, a little bit about MODI, and then we'll look at the long-term conditions that are associated with it and the acute effects. So long-term conditions account for a significant percentage of NHS time and resources. So about half of all GP appointments are spent looking after patients with long-term conditions. Over half of outpatient appointments, so those in the hospital on an outpatient, are spent looking after long-term conditions, and 70% of inpatients generally have a long-term condition. So it uses a lot of time and a lot of resources, which obviously means that it's expensive. So about 70% of the NHS budget is about 115 billion. About 70% of that is dedicated to looking after patients with long-term conditions. There's a charity called the King's Fund that I would advise you go and have a look at. There are links at the bottom of the slide, and this details how we can use NHS resources, etc., to manage people with long-term conditions. So long-term condition is defined as a condition that cannot be cured but is controlled by medication and or other treatment and therapies. So long-term conditions can be grouped into 6 broad areas, and those are diabetes, which we're going to look at today, cardiovascular, so things like hypertension and angina, problems with respiration, asthma, COPD, neurological problems, so things like MS, chronic pain, arthritis, and then the final group is other long-term conditions, which may include chronic fatigue syndrome, IBS or irritable bowel syndrome, and cancer. As you may expect, long-term health conditions become more prevalent, so more common as we get older. Okay, so you can see in the graph they're relatively uncommon in the younger patients, but as we get into our 50s and 60s, they become very common. So as well as being associated or correlating with increased age, long-term health conditions also correlate with socio-economic class. That is to say, in poorer populations, there's an increased prevalence of long-term health conditions. And long-term health conditions are becoming more common. So we can see from on the figure from 2004 5 up until 2014-15, there's a general increase in the prevalence of long-term health conditions. Not only that, there's also an increase in patients with multiple long-term health conditions, so multiple comorbidities. And why is that? Well, I'm sure we all know that the population is aging, life expectancy is increasing, we've got a bigger population of older people, and therefore given the correlation, the positive correlation between age and number of long-term health conditions, you would assume, as is the case, that there's also an increase in the total number of long-term health conditions that we deal with. So we're going to spend the rest of the lecture looking at diabetes, diabetes mellitus, and we'll look at the normal physiology of and how we actually regulate blood glucose. We'll then look at type 1 diabetes mellitus, type 2, gestational diabetes mellitus. We'll look at some of the treatments, and then in the second lecture that goes alongside this, we'll look at the acute and chronic complications associated with diabetes. So the pancreas is at the center of this story, and it's what helps to regulate blood glucose. And in the pancreas, you've got both exocrine and endocrine functions. And the endocrine cells, which we're going to think about today, are found in scattered groups in the islet of Langerhans. Okay, and these are scattered throughout the organ. However, they only comprise a very small percentage. Okay, very small percentage, 1 to 2% of the complete volume. And within these islet of Langerhans, you have different cells. You've got beta cells, which produce insulin. You've got alpha cells that produce glucagon. And then you've got delta cells that produce somatostatin. And insulin and glucagon work as part of a team. They are, in fact, the most important regulators of normal fuel metabolism. So we'll have a look at how insulin and glucagon work as a team. So insulin is synthesized in beta cells. It's got a molecular weight of 5,800 and a relatively short half-life of around 5 to 10 minutes. And that means we can regulate blood glucose over a short time period. It's initially screened as proinsulin, and when it's cleaved into the active molecule of insulin, we have an equimolar amount of C-peptide produced. Now, C-peptide has a couple of uses that you may have heard of. One is to differentiate endogenous from exogenous insulin in children with hypoglycemia. Okay, because if the insulin is being given by mum, for example, then there'll be no C-peptide. But if you've got a kid with hypoglycemia and you measure the insulin and there's no C-peptide there, then you know the insulin's been given by somebody. Okay, you would expect with insulin an equal amount of C-peptide. We can also use C-peptide, but more frequently in the urine. We look at the urine C-peptide to help determine when a patient may need insulin replacement. So as the C-peptide drops off, then the requirement for insulin increases. So there's a number of things that can stimulate insulin release, but the one that I really want you to remember is blood glucose. Increase in blood glucose, insulin release. How does that work? Well, blood glucose, rise in blood glucose is recognized by the pancreas. Okay, that'll lead to a change in the ATP-ADP ratio within the cell. This leads to closure of potassium channels on the transmembrane receptor, depolarizes this membrane, calcium influx, and therefore insulin release. So that's the one I want you to remember. There's also potentiators, things like gut hormones, and glucagon can actually inhibit insulin release. Neuronal control through both sympathetic and parasympathetic, and then pharmacological regulation. And we exploit the pharmacological drug sulfonylureas. So sulfonylureas essentially will bind to this potassium channel that we mentioned at the start of the slide, and close the potassium channel, therefore lead to depolarization of the membrane, calcium influx, insulin release, and that's without an increase in blood glucose. Okay. So the main function of insulin is to reduce blood glucose, and insulin works by a number of different mechanisms, but in adipose tissue and muscle you get increased glucose uptake. Okay, so insulin binds to insulin receptors on these cells and actually leads to a transporter upregulation, the GLUT4 transporter, that allows glucose to enter the cell. So you're reducing the blood glucose. Within the cell you then get increased either protein synthesis or lipogenesis. In the liver, you're going to switch off glycogen breakdown and switch on glycogen synthesis. So all these actions essentially will reduce the blood glucose. So the pathway then, we eat some food, the food's digested and metabolized, which lead to an increase in your blood glucose. The increased blood glucose is sensed by the beta cells in the pancreas, which is in the islets of Langerhans. You get the pathway we discussed, closing the channels, etc. Insulin release. Insulin will then bind to insulin receptors on muscle or adipose tissue and lead to the upregulation of GLUT4 transporters. GLUT4 transporters will then allow the increased blood glucose to enter the cell, therefore reducing blood glucose. So glucagon is the kind of the counter-regulatory hormone to insulin. Again, it's a peptide hormone, very small, 29 amino acids, molecular weight about 3500. As with insulin, it's synthesized as a prohormone, pro-glucagon, in the islet of Langerhans alpha cells, and in contrast to insulin, which is stimulated by high blood glucose, glucagon is stimulated by low blood glucose. Probably kicks in at about 3.5 millimole per litre. And as with insulin, there's also other stimulants, para and synthetic activity. It's inhibited by high blood glucose and insulin, and as I previously alluded to, its actions are to oppose that of insulin. So again, main actions of glucagon to increase blood glucose. And it does this by stimulating hepatic glycogenolysis, that's the breakdown of glycogen to glucose. It stimulates hepatic gluconeogenesis, that's the formation of glucose from other precursors, and it also stimulates lipolysis, which is the breakdown of fats for energy. And so the last couple of slides may have been a little overwhelming maybe, but what I want you to remember, if you don't remember anything else, really remember this slide. It's the complementary interaction of glucagon and insulin. Increased blood glucose, you're going to switch off your alpha cells, so you're going to switch off glucagon, and you're going to switch on your beta cells, your insulin. Okay, insulin release, decrease in blood glucose through the mechanisms that we've discussed previously. When we have a low blood glucose, so 3.5 millimoles as we said, we're going to switch on the alpha cells, the glucagon, and we're going to switch off the beta cells, the insulin, and that's going to increase blood glucose. So glucose homeostasis is very important indeed. Both low blood glucose and high blood glucose will have deleterious effects. Why? Well, glucose is the sole energy substrate for some tissues. Okay, so they can only utilise glucose. It's metabolised to pyruvate by glycolysis, and under aerobic conditions, pyruvate feeds into the TCA cycle. So that's the energy manufacturing plant of the body. Hypoglycemia can result in confusions, convulsions, and coma due to the lack of energy for the brain. And hyperglycemia can result in loss of glucose via the kidneys and long-term damage to proteins. So this is what happens when you have glucose. After a meal, for example, your blood glucose will either be converted and stored as glycogen, which is glycogenesis, or it will be used, converted to pyruvate, and which is used in the TCA cycle to produce energy, and that's called glycolysis. So when your body doesn't have any glucose, you can reverse those processes. So you can break down that glycogen that you've stored by glycogenolysis, forming glucose 6-phosphate, and therefore increasing blood glucose. Or you can use amino acids and lactate to convert them to pyruvate, and then through gluconeogenesis form glucose 6-phosphate and therefore increase blood glucose. And there's a couple of sources of glucose, as we've said. Diet, excess dietary glucose is then stored as glycogen, and fat. Okay, we've discussed these terms now. And then when we're fasting, in periods of fasting, we break down that glycogen or fats to form glucose. So we've gone through kind of the physiology of glucose regulation, and don't get too caught up on some of the technical aspects of it. I think as long as you can describe how the body, in relatively simple terms, can regulate blood glucose and familiar with some of the terminology used, you'll be fine. So now we're going to move on to the question, what is diabetes? Well, it's a chronic disease, and it's due to insufficient insulin production with or without ineffective use of insulin by tissues. And this final term, ineffective use of insulin by tissues, we sometimes called insulin resistance. It leads to hyperglycemia, so that's raised blood glucose, and in terms of long-term damage of this persistent elevated blood glucose, you can start damaging nerves and blood vessels and the kidneys. Now I'd want you to be able to discuss both the key features of both type 1 and type 2 diabetes. So type 1 diabetes, we used to call it insulin dependent diabetes mellitus, and we used to call type 2 insulin independent diabetes mellitus. Those terms have kind of fallen out of favour now, because some type 2 patients do end up requiring insulin administration. So just stick with type 1 and type 2. Now type 1 is generally due to autoimmune destruction of pancreatic islets. Okay, autoantibodies are going to bind to your islet of Langerhans cells in your pancreas and destroy them, a bit like autoimmune thyroiditis that we discussed in the thyroid lectures. It often presents in childhood or early adult life, and there's a genetic component, so there's a 15-fold increased risk if a first-degree relative has the condition. And almost all type 1 patients require insulin replacement, and before insulin was synthesized back in maybe 40s or 50s, 30s, 40s, it was a death sentence. So type 2 diabetes mellitus, so it's non-insulin dependent diabetes mellitus, but again, probably drop those terms now, is due to impaired insulin release. Okay, so the pancreas may not release insulin appropriately, but also insulin resistance. So earlier we spoke about how insulin will bind to these insulin receptors on muscle and fats, and through binding to that receptor you get upregulation of the GLUT4 transporter, which allows glucose to enter the cell. And insulin resistance is basically an impairment in this process. So either the insulin doesn't bind as well, okay, or binding to the receptor doesn't lead to the upregulation of GLUT4 transporters into the membrane. So impaired insulin release with or without insulin resistance. The onset is often in mid to late adult life. However, speaking from my own practice, we do have several patients, teenage patients with type 2 diabetes, and it's with the changing in diets and things, it's becoming more common in younger people as well. So this is the diabetes that's strongly associated with obesity. Does not usually require insulin treatment, but having said that, a significant number of patients will go on to requiring insulin in the end. And there must still be some kind of genetic component, or there's likely a genetic component, as there's a threefold risk for first degree relatives, but that risk is not as great as that for type 1. So this slide quite nicely summarises the difference between type 1 and type 2. Usual age of onset, type 1 less than 30, type 2 greater than 40. Insulin secretion, well, it's completely absent in type 1, but it's present but sometimes impaired in type 2. Insulin resistance is rare in type 1, but it's common in type 2. And obesity is rare in type 1. Indeed, these patients often are quite thin, but it's common in type 2. There's also a couple of secondary causes of diabetes you should be aware of. These can include things like infections, CMV, pancreatitis, tumours, hemochromatosis, endocrinopathies. So, for example, acromegaly, where you've got growth hormone excess, can lead to hyperglycemia. Gestational diabetes, so this is what can present in pregnancy, Downs, and also drugs, patient on corticosteroids. Now, we used to just think there was type 1 and type 2, but more recently we've actually identified a third type of diabetes, which we call MODY. It was, some people call it type 1.5. MODY, maturity onset diabetes of the young. We think it's, or it's saying it's unusual familial form, first recognised in 1965. It's characterised by a young onset, less than 25 years of age. It's not insulin dependent. It's autosome dominant inheritance. No association with obesity, and potentially accounts for 1 to 5% of all diabetes cases in Europe, which, given the prevalence of diabetes, means it's relatively common. Now, the issue with this is that some patients were wrongly categorised and therefore treated as type 1 or type 2. And actually, very recently, end of 2019, there's a publication from a group in Edinburgh that have a big diabetes unit, and they looked at all their type 1 diabetic patients and they screened them using urine C-peptide. And as we spoke earlier about urine C-peptide, you'd expect it to be very low, or if not undetectable in type 1 patients. But they found a significant number actually had urine C-peptide in the range that wasn't consistent with type 1 diabetes, and they've gone on to do genetic screening with genetic testing you can do for patients with MODY. We know what the mutations are, genetic mutations are, and they found that a significant number of these patients had MODY and not type 1. So there's now or potentially will be, a national drive to screen more of our type 1 patients with urine C-peptide to ensure that they don't actually have MODY. So the presentation of patients with type 1 is multifactorial, and it's generally due to the fact that you've got high blood glucose, but also because you've got low insulin, you can't actually, or undetectable insulin, you can't actually use that glucose. So you can't get glucose into the tissues, and therefore you need to switch to fatty acid metabolism. So if patients present with polyuria, which is increased urination and therefore thirst, and this is an osmotic diuresis, and that simply means due to osmosis, you've got increased glucose in the kidneys, filtered through the kidneys. That's going to pull water out of the body. Loss of weight, because you mobilizing fat and proteins because you can't actually use the glucose, and fatty acid oxidation leads to ketoacidosis. So the presentation of type 2 diabetes, they also present with polyuria and therefore thirst, again due to osmotic diuresis, itching, and then there's lots of complications, retinopathy, so damage to the eye, neuropathy, nephropathy, so that's damage to the nerves and the kidneys, vascular problems, problems with infection, and they do present often with gross hyperglycemia. So how can we diagnose diabetes? Well, we can measure blood glucose. We can do that in the clinic or the surgery. We can also look for glycosuria. Okay, so that's glucose in the urine. And both of these can be done as a point of care devices. You've probably seen the point of care blood glucose readers, which is shown on the right. A very simple test, pinprick blood from your finger. You drop it onto the testing strip. It's normally the glucose oxidase method actually in these, and that will lead to a current, and that current will be proportional to the amount of glucose that's in your blood. However, diagnosis should always be done on a laboratory sample. So if you've got a point of care blood glucose reading, that's fine. It may be suggestive of diabetes, but you should always confirm that result with a glucose that's been measured in the lab. And the criteria for diagnosis are based on the WHO criteria. Okay, so you can either have a fasting or a random blood glucose, and if in doubt, you can do a glucose tolerance test. But the WHO criteria for diagnosis are that the fasting glucose is greater than or equal to 7 millimoles per litre, or that the random plasma glucose is greater than or equal to 11.1 millimoles per litre, and that has to be in a symptomatic patient. If the patient is not symptomatic, then the test should be repeated. So I mentioned the oral glucose tolerance test. These have kind of fallen out of favour, and a lot of the time now we actually measure HbA1c, which we'll mention in a minute. However, it's still one of the kind of the gold standard tests. So the instructions would be for the patient to fast from 10 p.m. the previous evening. You can take usual medications, no smoking or exertion during the test. Sit the patient down, take a blood sample for glucose, and then you give them 75 grams of oral glucose. Okay, that used to be quite easy. It used to be equivalent to one of these regular bottles of Lucozade. However, they actually changed the sugar content in there a few years back, so you can't just use one of them anymore. And then you repeat the blood glucose 2 hours later, 120 minutes after, and the criteria would be the same as what we've mentioned previously. And we'll just recap them on the next slide. So yeah, the interpretation using the WHO criteria: diabetes greater than 7 or equal for fasting, greater than or equal to 11.1. So that's the diagnosis of diabetes using the WHO criteria. We've then got two other conditions: impaired glucose tolerance and impaired fasting glycemia. Impaired glucose tolerance, the fasting has to be less than 7, of course, otherwise it's diabetes. But the 2 hour one is greater than or equal to 7.8 but less than 11.1. And the other one is impaired fasting glycemia. So the fasting glucose is greater than or equal to 6.1 but less than 7.8. Now I don't want you to worry too much about the impaired glucose tolerance and impaired fasting glycemia. Just remember there's an increased risk of developing diabetes for both IGT and IFG. Some people may say it's a pre-diabetic state, and there's also an increased risk of, with IGT anyway, of macrovascular disease. So that's cardiovascular, particularly cardiovascular, but not microvascular complications. So a couple of case histories. Case number 1, we've got a 23-year-old man presents to his GP with a history of polyuria, increased urination, and polydipsia, increased thirst, over the last couple of weeks. He had lost almost a stone in weight. His urine contained glucose but no ketones, and his plasma glucose measured on a venous sample was 18.3 millimoles per litre. How would you interpret these results? Well, I hope you all got the same answer. Diabetic. You've got a venous sample that's measured in the laboratory of greater, it's not a fasting sample, remember this is a random sample, he'd not been fasting, but it's greater than 11.1, and he's symptomatic, so that is collectively diagnostic of diabetes mellitus. Is it more likely to be type 1 or type 2? Well, given the age and the fact that he's lost weight, it's more likely to be type 1. So case number 2 is a overweight but otherwise fit 49-year-old male, found to have glycosuria, so glucose in the urine, at a routine medical check. His plasma glucose measured at the same time was 9.2 millimoles per litre. So they did a glucose tolerance test, and the fasting was 6.8 and the 2 hour was 9.9. So how would you interpret these results, and how would you advise the patient? Have a think. So going back to the table that we showed, you should be able to deduce this patient has impaired glucose tolerance, which may be a pre-diabetic state, increased risk of developing diabetes and some of the complications, particularly the macrovascular ones. So we advise him with advice, lifestyle advice, lose weight, follow a healthy diet, for example, increase exercise, and if he was a smoker, to stop smoking. Case number 3. So we've got a 63-year-old woman who was seen in the ophthalmology clinic, and this was due to her deterioration in sight, and that was in bilaterally. She was found to have bilateral cataracts, so cataracts in both eyes, and direct questioning revealed that she'd been thirsty all of the time for several months. We had a fasting plasma glucose on the patient that was 10.1. What is the diagnosis? Have a think. So hopefully you agree that this is diabetes. You've got a fasting plasma glucose greater than or equal to 7, and the patient is symptomatic. She's both got polyuria and evidence of diabetic microvascular complications, in this case retinopathy. Case 5. So a GP uses a glucose meter to measure the fasting glucose of a 51-year-old lady with glycosuria. The fasting blood glucose was 9 millimoles per litre. So is this patient diabetic? Have a think. So this one is a little bit of a trick question. She's symptomatic, yeah, and you've got a glucose greater than or equal to 7.1. So they're both tick for diabetes. However, this is a point of care glucose measurement. You would need to confirm that glucose reading on a lab-based method to be able to say that this patient has diabetes. And we're not going to spend any time looking at the chronic complications of diabetes in this lecture. That will be in part 2. Very briefly, they can be broken down into microvascular and macrovascular. So the treatment of diabetes, your objective is basically to relieve the symptoms and prevent the long-term complications, and to do that you have to try and keep the plasma glucose concentration to as near as possible to physiological levels. There is, of course, a risk that the patient can become hypoglycemia. So depending on the age, for example, will depend on the risk of having to tightly regulate the glucose. For example, in our elderly patients, the risk of the chronic complications is lower, given their age, and therefore you may be willing to let the blood glucose sit a little higher than possibly in a younger patient. But again, the lower the blood glucose target, the increased risk of hypoglycemia. The options are diet, which can work in pre-diabetes, but often in type 1 and type 2 patients is not enough. Oral hypoglycemic drugs, so we mentioned sulfonylureas earlier, that's the one that binds to that potassium channel. And of course, insulin. So in terms of diet, you'd want to be advising reduced intake of refined carbohydrates. Increased exercise, of course, will always be beneficial. Oral hypoglycemic agents, sulfonylureas, which we mentioned, and metformin. So metformin actually reduces gluconeogenesis and increases glucose utilization. Okay, so you're basically going to help with the insulin resistance there as well. And insulin can be used as a bolus, so regime, which are injected, or it can be taken in biphasic forms. But again, there's a risk of hypoglycemia if the dosage is not tightly regulated. There's also newer treatments coming out, so there's now the what they call the artificial pancreas. It has a blood glucose reader, so it continually measures your blood glucose, and that's connected to an insulin pump. Okay, so you will inject insulin at a more physiological rate. As well as leading to hypoglycemia, the danger of insulin is that it can lead to long-term use, cardiovascular problems. So we can do a couple of things to monitor treatment. Firstly, we can look at blood glucose, so that includes measuring glucose in the lab, but also doing home glucose monitoring. And the target will be dependent on many factors, like we said before, age, etc. But broadly speaking, pre-meal or fasting 4 to 7, and postprandial or non-fasting after a meal less than 8. You could also look at glucose and ketones in the urine, but what we're using more frequently now is HbA1c, which is an indication of glucose over the previous 2 to 3 months, glycated hemoglobin. So glycated hemoglobin, or HbA1c, is formed by the irreversible non-enzymatic addition of glucose to proteins. The percentage of protein which is glycated depends on the half-life of the protein and the mean ambient glucose concentration. Therefore, glycated hemoglobin reflects mean glucose over the previous, say, 4 to 6 weeks. You'll see in the textbooks maybe it states 9 to 12 weeks, but the more recent ambient blood glucose level contributes more to the amount of glycated hemoglobin. So about 50% is accounted for by the previous 4 weeks. The target for HbA1c, again, factors include age, etc. But we'd be looking at 42 millimoles per mole, which is the units we should now use, would be excellent glycemic control, and once we get above 75 millimoles per mole, that would indicate poor glycemic control. And why do we care? Well, we care because there's a correlation between increased HbA1c, or poor glycemic control, and relative risk of complications. So as glycemic control levels increase, so does the risk of complications. And that's true for all the microvascular complications: retinopathy, nephropathy, and neuropathy, as you can see on the figure on this slide. So another case, 53-year-old male with type 2 diabetes, treated with diet. He attended the diabetic clinic, and he'd been testing his urine with Diastix once a week before breakfast, and the results were usually 1%. However, the HbA1c that we measured in the lab was 108 millimoles per mole. How would you interpret these results? Have a think. So the lab HbA1c indicates poor glycemic control, which would suggest that the results done on the sticks at home are inaccurate, either because they're faulty or because the patient's not using the right protocol for measurement. So what you could do, you could potentially suggest to test the strips in the lab or replace with a different lot of strips, and also retrain the patient to make sure they know how to use them. Just a point of note, urinalysis does not give any information about hypoglycemia. So another case, 22-year-old woman with type 1 diabetes regulated her insulin dosage 4 times daily. This was according to self-monitored blood glucose that she performed 6 times each day on 2 days each week. Her HbA1c result was 48 millimoles per mole. How would you interpret this result? So it's pretty straightforward. Adequate glycemic control. So HbA1c has got a number of significant limitations, and because of these limitations, you cannot actually exclude diabetes because of a normal HbA1c. You can only diagnose diabetes with the HbA1c. And you may not remember the details, but I want you to remember some of the limitations can be due to hemoglobinopathies, anemia, and renal failure. So hemoglobinopathies, so you can get an abnormal hemoglobin variant, and this can result in formation of glycated proteins other than HbA1c. Okay, so you're going to lead to a lower HbA1c than should be measured given the ambient blood glucose level. There is an alternative called fructosamine, which can be used for monitoring patients. It cannot be used for diagnosis. Okay, so HbA1c can be used to monitor glycemic control and also for diagnosis. Fructosamine can only be used to monitor. Anemia can get iron deficient anemia that can increase HbA1c, and then hemolytic anemias which can artifactually lower HbA1c. And then renal failure, a couple of things that can affect the HbA1c. One is that these patients can develop iron deficient anemia. A second one is that increased urea in renal failure can lead to hemoglobin variants which are indistinguishable from HbA1c with some of the hemoglobin methods. And you should probably go away and have a look at the different methods for measuring HbA1c, but briefly they can include HbA1c or immunoassay. So let's look at how, from a laboratory perspective, we can monitor some of the diabetic complications. First of all, nephropathy. So this is damage to the kidney. The first sign of nephropathy, the first sign of renal damage, really is the detection of protein in the urine, and this can be defined or determined as microalbuminuria. So we can measure the urine albumin to creatinine ratio in a first morning urine sample, and if this is greater than 2.5 milligrams per millimole, or 3.5 in female patients, it would be defined as microalbuminuria. So it's showing you that some of the proteins, i.e. albumin, is being lost in the urine, and that's because of damage to your nephron. Yep. We do annual assessments in diabetic patients. They'll have yearly assessments, and one of the tests will be a urine albumin creatinine test, or we may look at urine protein. We also do a serum creatinine test. Remember, creatinine is used in the assessment of GFR, glomerular filtration rate, along with some other parameters to get the estimated GFR. And when we see an increase in serum creatinine, this can indicate renal damage. And if you've got microalbuminuria and increased serum creatinine, so greater than 150 micromoles per litre, this suggests a high risk of renal nephropathy. And these patients should really be seen by a renal physician. They're often treated with ACE inhibitors. So in terms of monitoring retinopathy and neuropathy, the lab doesn't have a big role. Retinopathy, they have annual eye checks with an optometrist, and it can be treated with surgery, laser surgery. Neuropathy, annual examination of feet for circulation and sensation. Patients can develop what's called Charcot foot, and this is treated with surgery and specialist supportive footwear. So how about preventing cardiovascular complications, so the macrovascular complications? Well, the first thing to do is ensure good glycemic control, so we've defined what they are. Smoking cessation is very important. We don't want dyslipidemia, so you need to look at the cholesterol and the triglycerides. Remember, poor glycemic control will lead to dyslipidemia. Target cholesterol, the lower the better, okay? The lower the better. There's no real target, but the lower the better in patients with diabetes. And this is a QOF, which is basically a quality framework set by the NHS to ensure GPs target cholesterol in diabetic patients. And of course, one of the best treatments for hypercholesterolemia would be a statin. So we're going to look, we'll have a few slides looking at diabetes in pregnancy. And this is defined as gestational diabetes. So in the UK, there's about 650,000 deliveries per year. Now, about 5% of those patients will involve women who are diabetic. Okay, the majority of which is due to gestational diabetes. So they don't have type 1, they don't have type 2. They have simply developed diabetes during their pregnancy. And it's important to identify because it can be associated with a morbidity and mortality for both mum and particularly for the fetus. So the risk for mum, miscarriage, preeclampsia, preterm labour and rapid worsening of diabetic retinopathy. Risk for baby, stillbirth, congenital malformations, macrosomia and birth injury, so that's large size, perinatal mortality, and because they've been exposed to high glucose in utero, they can be prone to neonatal hypoglycemia, and that's because if the mum's blood glucose is high, then the baby's pancreas will respond by increasing the production of insulin, and therefore once the baby is born, the higher than required level of insulin can lead to hypoglycemia. So the pathophysiology of gestational diabetes is not fully understood. We know in healthy pregnancies there's increased insulin resistance from the second trimester. Why some of these women go on to develop gestational diabetes, we don't quite know, but it may be due to some women having increased levels of certain placental hormones which can oppose the action of insulin. So the advice for diagnosis is the 75-gram oral glucose tolerance test. Same criteria for diagnosis. It should be done between the 24th and 28th week of gestation. There's a number of things we can do to help manage these. Firstly, if they do have diabetes before they actually plan to get pregnant, make sure that's well controlled. And during pregnancy, lifestyle advice, diet and exercise, possibly oral hypoglycemic drugs, metformin, insulin, fetal monitoring, and ultrasound to check the baby's size. So this is important because good glycemic control in early pregnancy will reduce the risk of congenital malformations. Furthermore, the incidence of macrosomia correlates with postprandial blood glucose. So the higher the glucose after food, so the non-fasting blood glucose, the larger the baby. And if tolerated, you want to try and get the fasting blood glucose between 3.5 and 5.9, and the postprandial one below 7.8. Do not use the HbA1c to assess glycemic control in the second and third trimester, as HbA1cs will naturally fall. However, as with most things, this is currently being debated, and the evidence is almost supporting that we potentially will use HbA1c for diagnosis in pregnancy, but not yet. And don't forget about, we'll talk about diabetic ketoacidosis in the next lecture, but as in non-pregnant individuals, can be life-threatening for mother and fetus. So education and provide keto sticks for testing at home. So fetal monitoring is very important, and we've actually mentioned most of this. So you can get large babies, but you can also get small babies. So it's very important to look at, to use ultrasound to check the baby, but also there's something called umbilical artery Doppler ultrasound, and this can check for suspected impaired intrauterine growth. As basically in diabetic mothers, there's an increased risk that there's basically a block in placental flow of nutrients and blood to the baby, and if this flow is impaired in any way, it of course can lead to death of the fetus. Okay, so that's the end of this talk, really. What I'd planned to do is spend the last probably 20 minutes or half an hour going through the individual tests and discussing them as a group. So it might be worth, I mean, we've actually spoke about most of these anyway, most of these tests, but particularly as a laboratory scientist, this is where we should be able to shine. So we should be able to look at these tests, know why they're used and limitations, etc. So if you want to just go through the tests on your own, have a think about them. Any problems, give me a call or drop me an email. So very briefly, glucose, again, we can use it fasting or random, can be used for diagnosis and monitoring. HbA1c can be used for diagnosis and monitoring, but there's lots of limitations. Ketones we've not touched on too much, we'll mention in the next talk, but are very important to identify diabetic ketoacidosis. Lipids, remember diabetic patients are high risk for developing dyslipidemia. Renal function, one of the complications is nephropathy, so you need to think about renal function in terms of albumin creatinine ratio and serum creatinine, EGFR. Thyroid function tests, you want to be checking those. LFTs, some of the treatments can affect LFTs. Remember point of care testing glucose as well. ACR, PCR is albumin creatinine ratio, protein creatinine ratio. Okay, so we mentioned that in relation to renal function. Autoantibodies and insulin antibodies, we've not really mentioned those, but they are used in the diagnosis of type 1 diabetes. Okay, the autoantibodies which bind to the islets of Langerhans cells in the pancreas and destroy it, and leading to type 1 diabetes. Insulin C-peptide, we spoke about that, and we also spoke about urine C-peptide. FBC, and of course fructosamine, which again can be used for monitoring but not diagnosis.